maintenance. So we have to be careful with the word maintenance. Maintenance is the kind of word that does not inspire reimbursement. Reimbursement and maintenance often don't go together. So sometimes what you have to do with a patient who is NPO or who doesn't look like they're going to make, significant progress at the time when you're working with them is you're going to try and figure out what is the best plan or treatment plan that you can go with at the time, and then you may come back and reevaluate them later, right, if need be. So you would make recommendations and you would train the caregivers. So you would make some sort of recommendation as to the alternate feeding method. So, and usually you end up talking to the doctor about that. Is it going to be, a month, or is it going to be longer? How long do you think it's going to be before you're going to see any change? So let's say you have a patient who is it's kind of the difference between, let's say you have a patient whose electrolyte imbalance is totally out, and so they're out of whack, and so they're really confused, and they're cognitively not there, and you really can't even bring them to be assessed for a modified. They can't tolerate having the fees, and so they're going to need alternate nutrition until they can get stabilized. That's going to be somebody who's kind of short term, maybe that's 2 weeks or something. You're going to say to the doctor, well, hopefully in a couple of weeks this will be sorted out, so I'm thinking a short term alternate will be fine. And then the doctor's going to decide, is that going to be an NG tube, or is that going to be a dog cough tube, right? Something like that. Or if you know the doctor well, you'll just say, I think if we just, do an NG tube, that should get us through, through the next 10 days to 2 weeks. But let's say you've got a patient who is very severe. Let's say they had a severe brainstem stroke. And that, because we all know the medulla, right, is the center for swallowing. And so we're thinking, okay, this is going to be a long road to hoe. This patient's really got a significant swallow impairment, and they're not going to be able to maintain their hydration and nutrition. So for that patient, you're going to say, well, we need something long-term, right? And so then the physician's probably going to say, okay, we'll go ahead and put a peg in. So, so that's the first thing that's going to get decided. Then you're going to train caregivers. So if the patient is NPO, they'll just be NPO, and you'll train them on whatever exercises and that sort of thing that you want the caregiver to carry out. If the patient's not NPO and they can tolerate certain texture, let's say they're safe to have pleasure feeds, pudding or something, or pleasure feeds of nectar and pudding, so they can have a little bit of ice cream or chocolate pudding or whatever. So you're going to make those modifications. You're going to recommend if any strategies should be used to the caregivers. Often, not always, but sometimes as we decide if the caregivers want to come back for a reeval, let's say they're noticing something different, then we might need a calorie count, right? Before we pull the peg, we might need to know how much is the patient actually successfully eating orally. Sometimes they do calorie counts. When we finally got that dysphagia done yesterday, that patient's going to need a calorie count because it turned out her swallow is fine, but her cognition is so bad and she needs so much help with feeding that we're not sure that she's going to be able to maintain her nutrition and hydration, right? So we're going to get a calorie count for a couple of days to see how she does before they pull that NG tube and make a decision about whether she needs a peg or she doesn't. So, do you have to make any suggestions on the eating environment? So some of our patients patients, let's say you have somebody with a traumatic brain injury and they're easily distracted, they don't do well with a lot of noise, well, you have to train the caregivers on that, right? This is the type of environment that's going to be optimal for your whatever son or daughter, and you train them on that. Adaptive equipment, if you think the patient would benefit from, let's say, a special spoon, or sometimes they can feed themselves, but they have trouble, like they would, let's say they're ataxic or something, and they can't figure out, or they don't have that feedback on the force they're using, and so they go to pick up the food off the plate, but it often slides off. OT can get plates that have rims on the top, and so maybe if you think that they need any sort of adaptive equipment, you would ask occupational therapy to help you with that, whether whether it's adults or pediatrics. You also have to make a decision on how much supervision does the patient need while they're eating. So you would include that in your recommendation. Can the patient be left alone to eat? Does the patient need to have supervision? So somebody there 100% of the time during eating. And we talked about oral care way earlier and how important oral care is. And so you would also want to train the caregivers on that so that they know how to help the patient, particularly for an NPO patient. It's important that they try and keep the mouth as clean and work on oral hygiene, right, as possible, because that patient's not going to have any liquid, and so it's going to be harder for them to produce that serous saliva, and saliva that helps to keep the moisture in the mouth and decrease the potential for bacterial pathogens in the oral cavity. Okay. Does anybody have any questions so far? Good? Okay. Esophageal dysphagia. So very often we also pick up on the fact that even though the patient is saying that something's bothering them up here, it may be referred sensation from lower down, right? So when we do the modified, we figure out, okay, we don't see anything oral pharyngeal, we think sometimes we'll follow down, we'll see that maybe the bolus isn't, there's some esophageal dysmotility and the bolus isn't going down quite as it should. We can't make that diagnosis, right? And so what we do is on our report, we recommend to the physician that they refer their patient to gastroenterology or GI, so that they can be assessed for some sort of GI disorder. We can, even though we can't diagnose, we can make some simple recommendations to patients with GI or with esophageal dysmotility, or what we suspect is esophageal dysmotility. And so things like at night, you don't want to lay flat, so if you have the option of, pile up some pillows, because if you're laying flat, it's easier for the reflux, right? If you're up a little, that hopefully you won't reflux all the way up. So most people can't, don't have beds that elevate, but at least they put a couple of pillows up to try and elevate themselves a little bit. Stay upright for at least 30 minutes after a meal. The elderly, I once had a radiologist tell me that they should really be up for about 2 hours after their meal, that it takes them a lot more time, that whole digestive process. And so, and maybe that's why, they eat at 4:30. It's like, I don't know how many of you have ever gone to Florida, but my dad's in Florida, and when I go there, we always have to get to the restaurant at 4:30, and I always complain, and he always says, well, the lineup's going to be really bad if we go at 5. Right. So, anyway, so they have to stay upright after their be avoided that can aggravate GI and reflux, like peppermint, chocolate, spicy foods. It's kind of a little list of that. Avoid late